Gopal, well-known speaker from Chennai Apollo Hospitals. Now she is having a lab window, India, Chennai. She is known for various field in Apollo Hospitals and every dietary sector. She is working as an associate dean, and she has got so many awards from various institutes. The topic is thyroid dysfunction and female infertility. Over to you, ma'am.
Thank you. Good morning. Thank you, Chairpersons. So we had a very rousing talk by Sriram in which he also asked the questions and gave the answers. I think that's a new thing we should follow, Sriram, from now on. So today I'll be talking about thyroid dysfunction and female infertility, which is somewhat of a more limited topic. I'm going to keep it relatively simple. If you start getting into the controversial topics, there will be no sort of end to the discussion. I'll predominantly be talking about hypothyroidism and thyroid antibody positivity. Some time spent on that because that seems to be the most confusing. When do we measure? What do we do? And also hyperthyroidism, just one slide about certain aspects about its management. So let's start with a case as always. A 28-year-old lady is approached you. She's worried about not being able to conceive. She's been married for a year. Her periods are regular. She has regular working hours. More and more we are seeing these IT couples who have irregular working hours, and the disruption of the circadian rhythm is, and of course the husband and wife are hardly ever together at the same time. So, but in this case we will assume that both of them are working regular hours and they are together, no medical problem. So the question is, does she need to be screened for thyroid dysfunction? Show of hands if how many people in the room think she needs to be screened for thyroid. Yes, very good. My job here is done. Thank you. It's about 50%. Anyway, so subfertility, we know, is defined by a failure to achieve a clinical pregnancy after 12 months or more of regular, unprotected sexual intercourse. Female factors alone account for about 35%, male factors alone about 30%, combined 20%, and unknown or undefined about 15%. And where does the thyroid come into this? If you look at the prevalence of thyroid dysfunction in general, in reproductive age women, it is around 2 to 4%. And in women who are seeking help for subfertility, any amount of thyroid dysfunction is probably seen in about 60%, as you can see in this slide. So this is a very actually interesting slide I found. If you just look at the black bar and then you look at the white bar are the controls, people who are normal fertility, and the black are the ones who are infertile. So if you look at this last one, the chances of them being euthyroid are very high when they have normal fertility. The chances of them having a thyroid dysfunction, particularly subclinical hypothyroidism, are very high when they have infertility. So thyroid dysfunction and fertility are very much linked due to several reasons. Again, let's first concentrate on a couple of the reasons why the thyroid affects the female reproductive axis so much. T3 and T4 have direct effects on the uterus and in the ovary. The T3 and T4 is necessary for improving endometrial thickness and endometrial receptivity and to improve the response of the uterus to estrogen. It also has an important effect on the ovary for granulosa cell formation and for improving follicular cell count. Apart from that, the T3 and T4, due to the negative feedback effect, you heard about this in Dr. Vijay Bhaskar's talk, negative feedback effect through TRH and TSH affects predominantly the gonadotropin axis and also hypothalamic insulin signaling. So at various levels, there is this correlation between the thyroid axis and the female reproductive axis. So it is not surprising that any mild dysfunction in the thyroid can affect the chances of conceiving. And also, most important is that T3, T4 receptors and their normal working is needed for implantation. T3, T4 is necessary for proper trophoblast proliferation and this implantation of the embryo. So the European Thyroid Society guidelines from 2021, which is a relatively more recent guidelines, says that all women seeking medical advice for subfertility should be screened with a TSH and thyroid antibodies. They specify TPO antibody. We'll come back to that. So coming back to our 28-year-old lady, let's say her TSH is 3.7 and her free T4 is 1.4. And this is a normal range as was mentioned earlier. How many of you feel she needs to be on levothyroxine supplementation? I see about 3 hands going up. Okay. So this is the place where we have to actually also measure the thyroid antibodies. If the TSH is above 4, 4.2, above the upper limit of normal, certainly go ahead and get started on treatment with levothyroxine. Here, the treatment necessity to treat does not depend upon the antibody levels. Of course, if you are doubtful, repeat the test. If it wasn't a fasting sample, if you have other doubts, repeat it, but otherwise go ahead and get started. If the TSH is less than 2.5, do go ahead and monitor it at least yearly once. Women gain weight, it increases their TSH. So monitor it regularly if she is not conceiving. If the TSH is between 2.5 to 4, this is where you need to check antibodies and treat if antibodies are present in the high titer. And we'll come back to which antibody to measure. So in this lady, we measure her thyroid antibodies, and thyroid antibodies are high. So now how many of you feel she needs to be treated? The antibodies are high, TSH is 3.7. Okay, a few more hands, but basically she does need to be treated, and she started on levothyroxine 25 micrograms. She conceives in 4 months. At conception, her TSH is 3.5. Her dosage is increased to 37.5, whether you do 25, 50, 37.5, whatever it is, but she returns at 8 weeks because she's had a miscarriage. At the time of just after getting admitted for this treatment of this missed abortion, her TSH is 5 and her antibodies are repeated. Her TPO levels are higher, her TG levels are slightly lower. Now, what do we do in this situation? First of all, reassurance. I think we all know that. First pregnancy miscarriages are common. The other important point to keep in mind is the fluctuations of TSH are very common after any miscarriage or a delivery. So we need to repeat the blood test in about 2 to 4 weeks before adjusting the thyroid dosage. So I would probably leave her on whatever the higher dose you have increased her to in the pregnancy, repeat it and then decide what dosage you want to put her at. But what she is most worried about is that obviously Dr. Google has told her that thyroid antibodies causes miscarriages. So she comes and as endocrinologists we face that on a daily basis. What do I do with my antibodies? And this is what is responsible for my miscarriage. So thyroid autoimmunity or the presence of thyroid antibodies, what exactly does it refer to? So autoimmune thyroid disease is a group of diseases where the pathology in the thyroid, if you remove the thyroid gland and take a look at it, you will have a very characteristic picture. It is infiltrated with lymphocytes. Some sort of an immune pathology is occurring. Some other characteristics are it occurs in family groups. So there will be a strong family history. And another characteristic is in the same person, it may transition from being hypo to hyper, back to euthyroid, thyroid nodules. So you get a whole gamut of problems with autoimmune thyroid disease. It is not just you can be hyper, hypo, anything can happen, and postpartum thyroiditis. But ultimately, autoimmune thyroid disease for us clinically refers to the presence of thyroid antibodies in the serum. And these thyroid antibodies are present against the 3 common ones that we measure are anti-thyroglobulin antibody, the thyroid peroxidase antibody, which is inside the microsome, one of the subcellular fragments inside the thyroid follicular cell. Now, there is a little bit of a difference between the two. Thyroglobulin antibodies, think of it as your ANA. We know that above the age of 60 or 70, a lot of people develop antibodies in the general population. Thyroglobulin antibodies are like that. They are non-specific. They tend to be present in high titers. They are sensitive, but they tend to be non-specific. Levels increase with age. And they tend to correlate well with lymphocytic infiltration in the thyroid gland. The microsomal or the anti-TPO antibodies are actually more specific for autoimmune thyroid disease. So initial screening is sometimes done with this alone. Though I think we need to do both. I'll come to that in a minute. And we need to keep in mind that TG antibodies alone are unlikely to be positive, but we definitely see situations where one is completely normal and the other is positive. So we do see this discrepancy in the reports. Of course, the other antibody is the TSH receptor antibody, which is the antibody against the TSH receptor. Depending on whether it is a blocking antibody or a stimulating antibody, you get a hyperthyroid or a hypothyroid picture. Now, this is a sort of a table which compares the 3 antibodies, the TSH receptor antibody, the TPO antibody, and TG antibody. Just a few things I want to point out. Remember that the antigen for the TPO and the TG antibody, where it is. So the TPO, I said, is intracellular. It's a microsome. It is one of those cell organelles. Okay, and the anti-TG is actually intrafollicular. So inside the thyroid gland, inside the colloid is where the thyroglobulin molecule is sitting. So, but the TSH receptor is on the side of the thyroid follicular cell that is exposed to blood. What this means is usually you need to have some amount of thyrocyte destruction for the presence of anti-TPO and anti-thyroglobulin antibodies, whereas with the TSH receptor, we do not need to have this destruction of the follicular cells. TSH receptor antibodies generally tend to be in a low level and they tend to normalize, which is why Graves' disease, you might need to put them on medicines for 6 months or 1 year and then they normalize. Whereas TPO and TG antibodies persist. They remain for a long period of time. Once your body starts making it, it continues to be made and it doesn't mean anything much. There are some other subtle differences. The TSH receptor antibody is usually oligoclonal, mainly IgG1, but TPO and TG belong to multiple IgG classes. So even when one, say, subclass comes down, another subclass may come up. And the most important is this line, the action of the antibodies. I mentioned earlier that TSH receptor antibody can be stimulating or blocking, but the TPO and the TG antibodies actually have no defined action per se. They are markers for something else, but by itself they are not causing any problems, and this is something very important that we need to keep in mind when we try to interpret the blood values. Why do antibodies develop? So we do not have any particular specific reasons, but some protective factors have been found. Interestingly, smoking and alcohol intake seems to lower the antibody level. I'm not asking anybody to please go out and smoke and take alcohol, because even though your antibody level may be reduced, it increases your risk for Hashimoto's and Graves by a factor of 3. Selenium intake, maybe, it's a very controversial topic. Generally, there is a tendency sometimes to give selenium supplements to people who have positive antibodies. The literature is very, very confusing. Small studies show, but be careful about the maximum amount we use. Even at 200 micrograms a day of selenium, it seems to have a risk for increasing diabetes. So remember that it's not just a simple supplement at the doses we use, so be careful. Vitamin D supplementation seems to be a protective factor. Aggravating factors, high levels of oral iodine intake, viral infections, excessive cytokine production, exposure to polychlorinated bipheноls, plastic bottles, lithium, radiation, all of this may increase the production of antibodies, exogenous factors. Endogenous factors are, of course, genetic hereditary factors. In pregnancy, you have a change in the levels because of the change in the immune status. The antibodies against TPO and TG are associated with infertility and with a few other conditions. I'm not going into detail here. But as far as infertility is concerned, what does it imply? So this was a very good article which was published more than about 10 years ago now, which looked at its effect at various aspects of pregnancy. So one is, when you have positive thyroid antibodies, subfertility was more common, about 1.5 times. However, it did not seem to increase, it does not seem to affect the outcomes after IVF. So after IVF, if those of you who are practicing, say, fertility medicine, presence of antibodies should not worry you about proceeding with an IVF procedure. Clinical pregnancy rates after IVF are not affected by the presence of antibodies. In early pregnancy, there is association between positive thyroid antibodies and increased risk of miscarriage. And if you look at this, the risk of miscarriage is higher actually for thyroglobulin antibodies. It seems to be higher by a factor of 4 as compared to TPO antibodies, where the odds ratio is 2.6. So this is why I said I prefer to measure both, depending on what I'm going to do with it. But thyroglobulin antibodies are associated with higher chances or higher prediction or association with risk of abortions. There doesn't seem to be any other problem with antibodies. It doesn't affect the pregnancy in any other way, except that there may be a slightly higher risk of preterm delivery. This is very, very small number of studies, but overall during the pregnancy, there is no major problem with thyroid antibodies. Nothing to do with placental absorption, C-section, all of these things. Of course, higher risk of postpartum maternal thyroid disease. This is well known. So, when we see positive antibodies, what are we worried about mainly? What we are worried about is unexplained subfertility is higher, miscarriage is higher, recurrent miscarriage is higher, preterm birth and postpartum thyroid disease is higher. However, miscarriage after IVF or fertility rate after IVF is not affected. So coming back to why is this association even present? Why does autoimmune thyroid disease cause miscarriages? There are three theories. That the presence of antibodies is just indicative of a more generalized effect in autoimmunity. Your immune system for some reason is more hyper responsive to the stimuli that is floating around and that is preventing. I think that is the theory that most of us favor. It may also imply that the presence of these antibodies interferes with your thyroid function in some subtle manner that might prevent your optimal response to pregnancy. The other thing we need to keep in mind is some fertility rates are much common when women get older, where the fertility rate is going to be down, and antibody rate is also higher. It tends to increase with age. So it may just be a association that you're seeing by chance, because in both increasing age is a common denominator or a common factor. So what do we do if we see positive thyroid antibodies? If the TSH is above normal, above 4, treat. It's subclinical hypothyroidism. But what happens when the TSH is well within the normal range? Do we have any evidence to say that treating it helps? I'll just touch upon 2 studies. In this, they took women with thyroid autoimmunity. So normal TSH, positive thyroid antibodies who are undergoing IVF and embryo transfer, and they put one group on levothyroxine, one group on placebo, and the average TSH at baseline, so that you can see that it's not very high. In the control group 2.1 and treated group 2.9, similar, not levels that we would consider treatment. And you can see that there is no difference in the control group and the intervention. Intervention meaning they were given levothyroxine, no change in clinical pregnancy rates or live birth rates. So treating thyroid antibodies with a very normal TSH does not improve the chances of fertility after assisted reproduction, and will not reduce miscarriage rate or increase live birth rates. Another study also took a slightly different group of people. So people who had the anti-TPO antibodies and a history of miscarriage or infertility. So this was spontaneous conception. The median TSH in this group was 2, but the thyroid antibodies were high. Again, they put them on levothyroxine, and they were put on either 50 micrograms once daily or a placebo, a good number of people. Again, in this group also, the use of levothyroxine and thyroid peroxidase antibody positive women did not result in a higher rate of live births. So though we know that antibodies are seen more frequently in infertility and miscarriages, treatment of positive antibody women does not improve outcomes in pregnancy, whether with assisted or spontaneous. What does not help is telling women that the positive thyroid antibodies was responsible for their infertility. Because first of all, there is no data at all to say that that is what is causing it. It's just an association. What I would tell them is something in the immune system, maybe try and lead a healthy lifestyle. Do other things, cut out, we can talk about that, but no treatment is available as such for thyroid antibody positivity. For lack of time, I didn't put up the studies. They've tried steroids, they've tried IVIG, they've tried plasmapheresis. None of these things work. There may be a temporary drop in antibody levels. After about a month or 2, they just come back to baseline. So none of these things tend to work. If anything works, maybe get them to lose weight, get their insulin resistance under control. If you do that, maybe the antibody levels may come down. Women feel disempowered because they cannot do anything to control their antibody level, and they get disappointed or depressed because of this. So do we need to even measure thyroid antibodies? I'm saying it's of no use. The European guidelines are saying yes. When women present with subfertility, the European guidelines are saying yes, American guidelines no. Where it is helpful is only when you have borderline TSH value. Certainly check TSH in all women who are trying for pregnancy. A brief word about hyperthyroidism and thyrotoxicosis. Gross thyrotoxicosis interferes with ovulation, whether it's your spontaneous or assisted and ability to conceive. It's very much less common, hyperthyroidism. But once your thyroid levels return to normal, women will conceive. Only thing to keep in mind is anti-thyroid medications, whether it is PTU or levocortisol, carbimazole or methimazole. It is associated with a slightly higher risk of embryopathy, fetal embryopathy. So try to get them to do thyroid, whether with definitive means before they plan a pregnancy, if possible. It is just something to keep in mind. So these are the sort of guidelines in a nutshell. So if the TSH is more than 4, go ahead and get started on levothyroxine and check their thyroid levels every 4 weeks. Keep the TSH below 2.5. If the TSH is between 0.3 to 4 and their antibody negative, nothing more to be done. If they're antibody positive, check their antibody levels, consider treatment. If it's 2.5 to 4, consider treatment. However, in this group also, where the TSH antibodies is negative, remember that once you're going to put them on ovulation induction, they invariably gain weight. When they gain weight, TSH goes up. So keep monitoring their TSH regularly. Of course, if the TSH is less than 3, then it is a different matter. So finally, screen for thyroid function in all women who are seeking help for infertility. A TSH and a free T4, I think, is a reasonable first step in our country. Treat as per the guidelines and reassure as to the presence of antibodies. So thank you once again, and congratulations again to Aruna, Dr. Pinade, Dr. Raghuram, and the entire Madurai team. Thank you so much.
You put in a nutshell all the essential points which you did wonderful. But I think that aspirin cases being routine in all cases, they treat it regularly. That is a very important thing. And people who are not getting the pregnancy probably have to go for TSH and then antibodies also. That's also a good solution. Otherwise, they will. And as you rightly told, women they blame the thyroid hormones rather than they losing weight and no, they don't stick to our rules and they say blame it on thyroid. That always we see in many cases. Exactly interesting. Thank you, ma'am. Any questions? Question allowed again. Any doubts? With that, we conclude the session. Thank you, ma'am. Thank you for organizing.
Thank you. That was an awesome session, ma'am. As usual, precise, concise, to the point. I would like Dr. Ravi Kannan to state our speaker.